Good morning, everyone. Today, we're going to discuss bedside peritoneal dialysis catheter insertion in this clinical interventional nephrology program in Egypt, 12th to 20th of July 2021. A bit of bio about me. My name is Ben Lomatayo, currently practicing in Kenya, and I am also a fellow of clinical transplantation, Arab Society of Nephrology and Renal Transplantation. My interests in transplant nephrology and also I like intervention, and I'm doing several interventions in nephrology. My disclosure, I would like to thank ISN Ambassador Program because they supported me to come here in Egypt, especially my mentor, Professor Ahmed Ab. And I want to emphasize that I'm not an expert in this field. The talk outline, introduction, then brief functional anatomy of the peritoneal membrane, and broadly we'll discuss the methods of PD catheter insertion, and we'll focus mainly on the bedside PD catheter insertion, and also we'll see some catheter types. We'll discuss exit site care, and we'll end up by having a case. Peritoneal dialysis is a form of dialysis therapy, and it is complementary to hemodialysis. At the moment, at least 250,000 patients on peritoneal dialysis, and the practice varies worldwide. In some places in the world, PD is practiced as a first policy, or so-called PD first. So when you have the patient come in and requires dialysis, the first modality is usually peritoneal dialysis. And the leaders in this team, in this field, countries like Hong Kong, Thailand, and Mexico, plus some other countries as well. The main function really of this PD catheter is to allow bidirectional flow of the PD fluid in, out, without causing any obstruction or discomfort to the patient. Just to refresh our memory about the peritoneal membrane, and it is consisting of visceral and parietal peritoneum. Here in this illustration on your right, the parietal is in red, and then the visceral peritoneum in yellow. Between them, there's a physiological fluid between 50 to 100 mL, and the main physiological function of the peritoneal membrane is to allow movement of the viscera and as well as protection for the viscera. One of the most important concepts in peritoneal dialysis is the concept of three-pore models. So in this illustration, you will see on the left side, we have the capillary, and on the right side, we have the peritoneal cavity. And you could see those black arrows, which is one indicating the transcellular pore, and the other one indicating the small pore, and the last one indicating the large pore. So those three pores, you see around them, they are also different colors, green, and then the purple, the blue, and orange. Those colors represent uremic toxins as well as water. The transcellular pore, it's mainly allow the passage of water through the endothelial cells from the capillary side into the peritoneal side. There is some receptors there, the aquaporin receptors, that facilitate the passage of water from the capillary to the peritoneal side. It is similar to aquaporins, which is present in the distal nephron. However, this one is not under control of ADH. The main function of the small pore is actually allow the passage of small molecules like sodium, potassium, phosphate, urea, and creatinine, while the large pores allow the passage of a bit larger molecules, stuff like a beta-2 microglobulin, which is usually get dialyzable after a long dwell time of at least 6 hours. So in brief, these are the pores that allow passages of the molecule between the blood side and the peritoneal side. Small pores for urea and creatinine, large pores for beta-2 microglobulin, and transdermal pore for water, which actually helping you with the ultrafiltration. Methods of PD catheter insertion in broad terms, we can do it open surgical and then through laparoscope, and recently also interventional radiologists, they have joined the field of PD catheter, and they can now place this catheter effectively by the help of ultrasound and fluoroscopy. Today, our domain, I highlighted there in black, the bedside catheter placement, which is the primary function of the nephrologist, and as well as non-nephrologic colleague, from medical officers to physicians and even nurses. If they are trained well, they'll be able to place the bedside PD catheter insertion. There are some key facts and key basics we must keep in mind before proceeding with a bedside peritoneal dialysis catheter. Like every other situation in medicine, you always like to know the history of the patient, and here we focus on history of surgeries because this might render the procedure either absolute or relative contraindication. Physical examination is essential. Look at the BMI, look at the surgical scars, the presence of hernias, because sometimes those hernias, we repair them before the PD catheter placement, or we can place the catheter and then we repair 2 weeks later. Some patients, they can be on blood thinner, anticoagulation for the cardiac reason commonly, and in that situation, before to proceed, you would like to stop them for at least 5 days, unless this is the situation of urgent to start PD. Bowel preparation, important practice. Use oral laxative, avoid phosphate enema, especially the night before the procedure, so that you decrease the distensibility of the colon and make the process of the PD is very easy, because constipation is one of the enemies that can be associated with dysfunction of the PD catheter. Some people, they place this catheter under conscious sedation. In that situation, you would like to keep the patient at least 6 hours MPO. Concern, again, we would like to discuss with the patient the process of the peritoneal dialysis catheter placement, the advantages, as well as the risk associated with this procedure. Keep in mind, they are minimal, but things can go wrong at any time. You can also give the patient the options of not to proceed with PD catheter. Antibiotic prophylaxis is also another important practice to reduce the risk of peritonitis. So the choice is between first-generation cephalosporin, cefazolin, or vancomycin, depending on the allergic profile of the patient. Always empty the bladder to reduce risk of a bladder injury. And if you have a patient with a bladder dysfunction and obstruction, you would like to place a Foley's catheter. These are type of catheters. The straight one on your left is the standard Tenkov catheter, which was designed by the Tenkov at the early days of the PD catheter, and then it's followed by some modification, the swan neck catheter, and also we have a coil catheter. In terms of which catheter is better, I think there's no difference much between all of them. It depends on what's available for you and your experience. Important landmark, when you are trying to place the peritoneal dialysis catheter, it's important to allow the patient to stand, and then you place the tip of your catheter against the symphysis pubis, so that to allow that tip to be in a deep pelvic position. This also helps you to decide the puncture site, whereby you're going to introduce your needle, your dilator, and then the catheter through. This is procedure should be done under sterile environment. Everything should be aseptic. Yourself, as the operator, as well as your assistant, and all the environment basically need to be in a sterile fashion. Just to familiarize ourselves with the component of the catheter, on the left side, this is the catheter which is now sealed. After we open it on the right, we'll see the blade, we'll see the syringe, the needle, the guide wire, the pillar wedges, the catheter, as in this case, this is the coil type of catheter, and then we have some clamps and caps for the catheter. The procedure for bedside catheter insertion, I prefer we discuss this when we are placing the catheter in the workshop and the hands-on, rather than being theoretical at this point. Remember this illustration just to show you that the catheter is away from the midline, especially linea alba, and you can see the two curves, and the catheter is passing through the rectus sheaths and muscles. Same illustration here. In this case, you have the coil catheter. Remember, the deep curve should be in a peritoneal position, and the superficial curve should be at least 2 centimeters from the exit point. Once you have done the catheter, you'll see something like this. In the middle, the puncture site, and the left, you will see the exit site. And now there's another catheter, we call it the extension catheter, which is now connected to the peritoneal dialysis catheter, and the patient is ready to start PD. Important practice is to have a KUB X-ray post-procedure, just like we were doing for canal dialysis catheter, to ensure that you have your tip of the catheter in situ, because migration of the tip of the catheter is one of the acute complications of the PD catheter. So it's very important to do the chest X-ray to ensure that you are in the right position. Exit site is another aspect of PD also, which is very important, especially the care. The advice is best to clean or to dress the exit site with a normal saline. Avoid use of iodine because of risk of tissue damage, and this can be followed by infection. And the use of antibiotic prophylaxis is also very important for the exit site care. And depending on your experience, and then depending on the availability, the choices are between mupirocin or gentamicin. There is no immersion basis for 21 days. Only sponge basis is allowed, and you must keep the exit site completely dry until the healing after 21 days. Patients should be advised not to lift any heavy weight more than 5 kg until 4 weeks after the procedure. The bedside PD cassette has a lot of advantage, and one of them is the nephrology team is always in charge. They can decide on the time of when to place the catheter, and also the follow-up, and everything really coordinated in one place, which is the renal unit. The other advantage is urgent to start PD is possible, and we have seen in the era of the pandemic COVID-19, one of the infection control measures is patients should dialyze in their own place, and urgent to start PD has been utilized in many places in case of COVID-19, just a bedside technique. Again, if you compare to the surgical technique for patients who are uncomplicated, the outcomes are similar. And the other advantage for the bedside PD catheter is a cost. So it's done by nephrologists. You don't need to look for the surgeons, the anesthesia team, look for the theater space and then recovery and all those stuff. One thing I want to emphasize on, yes, as PD is a very good modality to hemodialysis, so no one is better than other. But the situation that we are trying to use the peritoneal dialysis in patients with end-stage access disease is something that associated with usually poor outcome, because most of these patients, when they reach that stage, they don't have residual kidney function, and we know PD works hand to hand with residual kidney function. This is the example of a small boy, which is we have just seen recently referred to our unit, 15 years old, on hemodialysis in the last 5 years, complete access failure, and off hemodialysis for 1 month, you could see creatinine 2,000 micromole per liter, urea more than 40, K 6.8, and hemoglobin is 8. So this is a very desperate situation, and at the same time, we also don't watch the boy dying. So we start binding the potassium, and we started him on area to start PD, although we know that this is a very difficult situation. In the middle, we just start him with temporary hemodialysis catheter, because at that point of encounter, we don't have the standard peritoneal dialysis catheter, but we got it the next day, and the boy continued his peritoneal dialysis. Unfortunately, he died after 12 hours of peritoneal dialysis because he developed aggressive pulmonary edema, and we intubated. We have done everything possible, but again, it's just not a suitable case for peritoneal dialysis. That's the end. Thank you for listening. I'll be very happy to hear your comments as well as questions. Thanks.